Hello everybody, in this video we will talk about the Achalasia. This is the second lecture of GIT and we will talk about 294 file and routine break questions too. Let's talk about the definition of Achalasia. Actually, achalasia mean is relaxation. And when we add a at the first of achalasia, it's converting the meaning to negative. It's mean absent. So absence of relaxations. Achalasia mean basically absence of relaxation. Achalasia is esophageal motility disorder characterized by impaired relaxations of the lower esophageal sphincter. This is very important. Actually, the problem is in achalasia in the lower esophageal sphincter and peristaltic contractions in the distal two-thirds of the esophagus due to degenerations of inhibitory neurons in the myotomic plexus. So normally, normal esophagus, when food coming down from the esophagus to the near to the lower esophageal sphincter, so it getting relaxed, it's getting open, and food passing through this sphincter to the stomach. But in the achalasia, the problem is that the lower esophageal sphincter doesn't relax. So when it's closed, the food coming here and stacking here in this area, distal two-thirds of the esophagus. So this part of the esophagus getting dilation. So it's looking in the endoscopy dilation. There will be dilation endoscopy. The causes of achalasia is unknown, but may be associated with the autoimmune process, genetic factors, and viral infection. One of the most common cause of achalasia is a bug which is called Trypanosoma cruzi. This is very important and very high ill. This bug can lead to a very classic triad in which include dilated cardiomyopathy, number 2, mega colon, and number 3, mega esophagus, which mean achalasia. So this is very important. One of the secondary causes of achalasia is a bug which is called Trypanosoma cruzi, and this can lead to a very classic triad which is called dilated cardiomyopathy, megacolon, megaesophagus. And the clinical feature, achalasia is like the first symptom of achalasia is dysphagia to solid and liquid. This dysphagia can be progressive or paradoxical dysphagia. What does paradoxical dysphagia mean? When there is only difficulty with swallowing of liquid, not with solid. When only difficulty present with the swallowing of liquid, this is called paradoxical dysphagia. Second, we have the patient will have regurgitations and also retrosternal pain and cramps. Patient will have weight loss, nocturnal cough. The diagnosis of achalasia. The best initial test for achalasia to diagnose achalasia is upper endoscopy, which is very important for the diagnosis. Endoscopy is very important to rule out pseudoachalasia or other cause of obstructions of the esophagus. So what you will actually find in upper endoscopy: retain, saliva, or food. Before I talk about here in the start that if the lower esophageal sphincter doesn't get relaxed, so this will lead to retain of food in the distal two-thirds of esophagus. And esophageal dilatation, so when the food getting stuck there in the two-thirds of distal of esophagus, so obviously it will getting dilation. Most accurate test, if they asking you about the most accurate test for achalasia, then you should go for high resolution manometry. This is very important, and manometry is gold standard to confirm achalasia and determine the subtypes of achalasia by measuring what we measuring in manometry: the lower esophageal sphincter pressure and esophageal peristalsis. So the finding of manometry, you will find here the absent or uncoordinated peristalsis in the low two-thirds of esophagus. This is very important. This is the finding of manometry and achalasia. And also you'll find impaired relaxations of lower esophageal sphincter. It will be incomplete relaxation or maybe totally absent, complete absence of lower esophageal sphincter relaxation. With increased lower esophageal sphincter resting pressure, this is very important. Next we have barium swallow. Is useful when manometric findings are unclear. When you do not find anything and the manometry finding is unclear, you should go for the barium swallow. So in barium swallow, if you give to the patient, you will find two things: an X-ray, the very big sign, which is very important, and this appearance is characteristic for the achalasia. So in this picture you will see the proximal esophagus with stenosis of gastroesophageal junctions. This is very characteristic for the achalasia. So here you see the proximal part of the esophagus getting dilations, and here you see the stenotic part, and this appearance is look like very big appearance on the X-ray. So this is very important. Next you will find delayed barium emptying or barium retention. So there will be delay in the barium retention, there will be delay in the barium emptying, and you will see barium retention in the lower two-thirds of esophagus. The first line definite treatment option are pneumatic dilatations, which is indicated for type 1 and type 2 achalasia. Second, we have laparoscopic hilar myotomy, which is indicated for type 1 and type 2 same. Third, we have peroral endoscopy, endoscopic myotomy, which is indicated for any type of achalasia, and more prefer definite treatment for type 3 achalasia. In the pharmacological treatment include botulinum toxin injection. This botulinum toxin is injected into the lower esophageal sphincter, and it's indicated if the first line options are unsuitable. Next we have oral medications. In oral medications we have two types of drugs: calcium channel blocker and nitrates. These medicines provide short-term relief of the achalasia symptoms. Next, the very crucial part of this lecture is 294 file notes plus question Q bank PT1 question bank answers. The first is 294 and then the Q bank PT1. question answers. So the first question about the achalasia in 294 is a patient presented with dysphagia. On manometry, you find that he has absent normal peristalsis and increased lower esophageal sphincter tone. This is very important. Increased lower esophageal sphincter tone. What's your diagnosis? So obviously the diagnosis will be achalasia. Second question, a patient presented with dysphagia, nausea, and vomiting. On chest x-ray shows a dilated esophagus. Before I talk about this, that become narrow in the lower one third. In the lower one third is become. So lower one third narrowing genetic part is indication is obviously show the very big sign on X-ray. If you doing to the patient's barium swallow, so and X-ray you will find very big sign. Before I discuss about this sign, what is the diagnosis? So this sign is, before I told you that this is characteristic appearance of the achalasia. So the right answer here is C. Next, a patient with dysphagia, nausea, vomiting, and narrow lower one third of esophagus and dilated esophagus on X-ray. So what is the diagnosis? The diagnosis is achalasia. Number C is, the C option is correct. Women who experience dysphagia, manometry done in show increase lower esophageal sphincter tone. So this is a very specific manometric find, and this is obviously achalasia. This was all about the achalasia, and next lecture we will talk about gastroesophageal reflux disease.